Hello everybody and welcome back. This will be your video lecture for Chapter 42, Multi-System Trauma and Trauma Resuscitation. I hope everybody's doing well. Let's dive right into this. Let me introduce the chapter. So we're going to talk about significant MOI. Patients sustain injuries to more than one body system. When multi-system trauma occurs, morbidity and mortality are increased. We'll talk about why. Advanced EMTs must consider the overall impact of multi-system trauma, manage immediate life threats, begin transport to the closest appropriate facility, and do not become distracted by injuries, which are graphic, when others may exist that are actually life-threatening. We'll talk about that. So our goal is always in trauma is to minimize time on scene to initiate transport as soon as possible. We need to concentrate on working as a team to assess and treat immediate life threats and package patients for transport. Manage the airway, breathing and circulation, make preparations for further care and transport while you wait for patients whose needs to be extricated. So let's talk about these real quick. I know that, it's just like when we're doing CPR, right? And we're doing high quality CPR and we're swapping out compressors every 2 minutes. We're jumping right back on that chest as soon as the AED shocks. We have to work as a team when it comes to trauma too. And so what I mean by that is, let's say for instance, you have someone suffering a gunshot wound. You get there, you've got your team there, folks. What's super important is to identify, in our case, we have AMR, but to identify who is driving the ambulance or the rescue, who's driving that today. Because when you're on the way to the ambulance, that person should be not participating with patient care. That person should be moving towards the front of the truck, getting in the driver's seat, putting their seatbelt on, and ready to go as soon as the rest of the care team loads the patient in the ambulance. Once that patient is locked in the back of that ambulance, there's no need to sit there and do anything else. We can do everything that we need to do while we're on the way to the trauma center. We can expose, all the IVs can be started en route. Further care can be done, right? So there's just not a need to be sitting there trying to start an IV or trying to do things, because 30 seconds could matter in this case. A minute can matter in this case. A minute to get quicker to the OR, remember, our IV fluids don't carry red blood cells, so they get blood a minute sooner. And believe it or not, receiving blood a minute sooner can mean the difference in life and death. So that is super important. Also, let me discuss this real quick too. We talk about making preparations for further care and transport while you wait for patients who needs to be extricated. We need to be in the car with these people. If we can get in the car while extrication is being completed, there's a lot of things that can be done. Airway management can be done, right? We can assess the patient from there, and we can start thinking, okay, once we get to the ambulance, what do we need to have prepared for this patient? And otherwise, we may not know that if we're not in the car while extrication is being completed to be able to anticipate those needs. So scene size up, first priority is obviously you and your partner. Never attempt to access patients until all hazards are controlled. You need to request additional resources. Care for only one critical patient at a time. And, it tells you to follow your EMS service policies with regard to who's approved to accompany you during transport. But let's talk about a few of these. A lot of these calls involving traumatic situations are involving scenes that potentially may not be safe. And violent crimes is one of those cases for sure. But let's don't ever forget, there's a lot of hazards involved in the motor vehicle collisions. Make sure that that you have a vest on if you're in the roadway, that people can see you, that there's appropriate lighting on the scene. If it's dark outside, making sure that you're looking for down power lines, things like that. Those are things that can kill you. And you have to think about those types of things, even when they're not there, because if you get in a good habit of taking a minute to survey your scene, just like you do on a fire call when a 360 is complete, take a second to do a 360 on your trauma scenes, and think about what could hurt us here and what can we do to mitigate that. Requesting additional resources. We need to request those resources as soon as possible, right? Because you can only take care of one critical patient at a time. And so you need to make sure that you're calling for those resources at the appropriate time. If ALS is available, consider requesting them according to your protocols, right, for critical trauma patients. Want to determine the most appropriate facility, determine the best way of transporting that patient, and determine where air medical transport is beneficial. So, yes, if ALS is available and they can make a difference on some of these calls, but let's just be quite honest, the only person here that's going to make a difference in this patient's care is a surgeon. We need to get that patient to that surgeon. So we can manage most of the airway issues. We can manage bleeding control. We can start IVs. We can manage that trauma patient quite well until we get to the facility. So let's really consider before we call ALS, is this something that we can handle? And if so, let's get that patient to where they need to be. MOI that can lead to multi-system trauma. So let's look at these. Ejection from a vehicle, a pedestrian struck by a vehicle, fall greater than 10 feet for adults and children, and motorcycle and rider separation in MVCs. So again, recognizing the MOI goes a long ways in recognizing that your patient, irregardless of how they present to you at that moment, can be sick. The patient may be sicker than we think. MVCs greater than 40 miles per hour, an explosion, multiple penetrating traumas, especially to the head, neck, and torso. Use MOI to help determine the need for manual stabilization of the head and neck. Here we have a picture of a motorcycle collision that results in a multi-system trauma. And it makes sense because motorcycles riders aren't protected by the vehicle. Primary assessment, we want to manage life threats before moving on to other components of the assessment. So if you have an airway problem where you need to suction the airway, we can't move on to breathing or circulation until we know the patient has a patent airway. I mentioned teamwork earlier. Teamwork is essential. Patients with trauma to face or neck may have inadequate airways. And so, again, we need to anticipate that and be prepared to suction. Use manual airway maneuvers, basic adjuncts, and advanced airways as needed. So if you have a difficulty managing an airway, request ALS or air medical transport or transport the patient without delay. We don't do a lot of air medical transports in our area, so it's not a big deal for us because we have the luxury of being able to be at a trauma center rather quickly. However, there are times even in our area where we might consider air, like they're doing road work on I-20, and that leads to Grady, and they're doing I-20 westbound road work, and 3 lanes are closed, and you're in 17's immediate. Sure, yeah, I would definitely consider calling an air ambulance for that situation. Airways can be difficult. I've had a few in my career that have been difficult, and so you have to make decisions very quickly. One of those in our system being very dynamic with a mixture of BLS, ALS vehicles, is this an airway that I'm going to call for ALS? And while I'm waiting for them, time is ticking. And so you might want to consider, contacting your closest facility. Even though it's a trauma patient, if we don't have an airway, we may need to go to a non-trauma center till we can get an airway, like Hillendale, DeKalb Medical Center, just to name a few, right? Go to your closest facility. Most emergency room physicians, they have access to drugs where we can paralyze the patient, and now we have all the video tools needed to confirm tube placement. So that might be something that we have to consider, but you need to consider the time factor in waiting for another piece of transport equipment with a paramedic on it, or is this something that we would be better off transporting quickly to the local ER? Level of responsiveness and airway status can deteriorate, and it can happen rapidly. Anticipate changes and be vigilant to detect them. So we see this a lot. You have someone to start with who has an altered level of responsiveness, right? So that should cue you in. Even though right this second my airway's good, you should be thinking in the back of your mind that, hey, it might be good now, but it may deteriorate very soon. So I need to make sure I'm paying attention to airway sounds and make sure that I'm paying attention to chest rise and fall. But yeah, we're gonna when we're talking to the patient's hoarse, right? The patient starts having stridorous sounds. Patient starts trying to clear their airway by grunting. All of that should start cluing us into an airway that's properly compromised. If ventilations are inadequate, consider the cause. So decreased responsiveness, TBI, spinal cord injuries, injuries of the chest, wall, or lungs. Cover open wounds to the chest immediately with an occlusive dressing. And if you suspect a tension pneumothorax, request ALS transport without delay. So yeah, in situations, we have to try to identify where is the problem coming from. Is this a spinal cord injury causing respiratory depression? Is this a pneumothorax causing respiratory depression? And how do we fix it? If it's an open chest wound, we cover it. 3-sided occlusive dressing with a bleb valve is the way to go. And we call ALS. Paramedics can do a chest needle decompression. All of those are things that we, not only do we have to treat the patient in front of us, but we have to try to get one step ahead of these situations where we can anticipate where we're going with the call. Assess pulses to determine whether perfusion is adequate. Immediate control of external hemorrhage with direct pressure. If you cannot control external bleeding to an extremity, apply a tourniquet and keep the patient warm. We have to get in a good habit of feeling for radial pulses. Feeling for a radial pulse allows you to understand that how fast the radial is moving, if it's weak or strong, and it tells me that their blood pressure is 90 systolic. All of that just from feeling a radial pulse. And so we have to start becoming really good at being one of the first things that you do is feeling for a radial pulse, because it tells you so much. We're going to control any type of external hemorrhage at the beginning of the call. And if you can't control it with direct pressure, your next step is to apply a tourniquet. All right, and so here's a image of a air ambulance, and its title is "Use Air Medical Transport when necessary to transport multi-system trauma patients directly to a trauma center." And that's all good, but I want you to understand that understanding the whole call and how this works, right? You have to set up an LZ. The helicopter has to land somewhere safe. The patient has to be near that LZ or move to an LZ. Once the helicopter paramedic comes off of the helicopter, they're going to assess the patient. That's going to take a few minutes. Then the loading process begins, where we have to load the patient onto the helicopter. And sometimes it's not quite as simple as just throwing them on the helicopter. So count that time in when you're calling for it. Now, if you're in Butts County or you're out in Morgan County, you got 10 minutes for that helicopter to be on the scene, versus their probably 15-minute transport time to a trauma center versus 50 minutes by ground. Yeah, it's a no-brainer. But here in our county, those are things that we do have to consider because we are so close to a trauma center. Transport decisions. Critical trauma patients, transport to a level 1 trauma center without delay, or transport to a closer facility for interventions and stabilization before transport to a level 1 trauma center, or consider air medical transport. So all patients who meet mechanism or who suffer multi-system trauma, they should go to a level 1 trauma center. Without exception. You need to understand, if you choose a closer facility, the only intervention that we should be going there for is for airway management. If you decide to go to a closer facility with your level 1 trauma patient, understand you're delaying care, and that could mean the difference between life or death. So please only go there for dire emergencies. Only if you have to. So what are transport decisions for the critical patient? Inadequate airway, inadequate ventilation, dyspnea, suspected pneumothorax, flailed chest, significant internal or external hemorrhage, and decreased level of responsiveness. Penetrating trauma to the head, neck, torso, or extremities proximal to the elbow or knee. An amputation proximal to the wrist or ankle, trauma with significant burns, 2 or more long bone fractures, suspected pelvic fracture, an open or depressed skull fracture, signs and symptoms are shock. But, pretty much all of that we should be going to a level 1 trauma center with. I get it. Some of these are going to be hard for us to care for, but we can rendezvous with an ALS unit if we need to for those suspected pneumothoraxes. If it's a flailed chest, we could provide positive pressure ventilation for that, etc. Figure number 42-3, it's titled 2011 Guidelines for Field Triage of Injured Patients. You should go through this and kind of be familiar with this, of how this field triage works. When we talk about the secondary assessment, that's super important, because this will allow us the opportunity to find injuries that we may have not discovered before, and some of these injuries might require life-threatening care. So rapid trauma exam for your critical trauma patients. Prepare to package that patient, get them to the ambulance. In the secondary assessment, that's when we do the baseline vital signs. We will feel for a radial pulse prior to that, so that'll give us an idea of cardiac output. But this is when we'll actually get some numbers. We're going to do that head-to-toe exam. We can use our cardiac monitor, our pulse ox at this point, and this is when we contact the receiving facility. Multi-system trauma patient packaging, spinal motion restriction if suspected spinal cord injury, stabilize extremities by using taper straps. We're going to reassess every 5 for the critical and every 15 for the non-critical. We're going to watch for trending vital signs. And remember how these vital signs should be affected. We should see if the patient's critical, systolic blood pressure coming down and diastolic blood pressure rising. Critical trauma patients are at high risk for shock. Shock is also, it can be defined even as cellular hypoxia or leading to cellular death. The goal, maintain adequate cellular perfusion to prevent irreversible organ damage. Patients must have adequate blood volume, mass of red blood cells, cardiac output and blood pressure, ventilation, internal and external respirations. So look at this for a second. Adequate blood volume. It doesn't say adequate sodium chloride volume. It doesn't say adequate plasma volume. It's adequate blood volume. That includes red blood cells. That's what ultimately the patient needs. And praying one day that we can get blood delivery here at DeKalb County. We're surrounded by services who are doing it. It will save lives in our area as soon as we get it. And so if you see Dr. Carr and you know he's actually passionate about it, he wants it, but the leaders of this department need to hear this from you. They need to understand that you get this. They need to understand that you care about our citizens and you want them to survive multi-system trauma. And blood is the only way patients can survive multi-system trauma. Once hemorrhage is once hemorrhage is controlled, IV fluids can help restore vascular volume. Absolutely. Once you get blood flowing into that patient, absolutely we can bolus them with fluids to help vascular volume. That will go a long ways. But again, without that oxygen carrying capacity, can only be restored through the infusion of red blood cells. Fluid administration increases the MAP to the mean arterial pressure to improve tissue perfusion. Well, our goal for MAP here, it should be 60. Well, that's what the goal is. And sometimes you can have a blood pressure of 88 over 50, and they'll have a MAP of 60 to 65. That's what we're looking for, but it's different for each patient. But the MAP is what we're actually looking for. Intravenous fluids raise blood pressure. The increase in blood pressure may come at a cost of increase in bleeding, hemodilution, and hypothermia. This is what, when IV fluids first come out, it came out during the Vietnam War. And we thought, okay, hey, we're going to have a lot more survival rates of these soldiers in wartime setting because they had trained medics to start IVs and actually in the war zone. And what they were learning when they studied it, like their first, I think it was first year of combat. No, they were actually, when they compared it to World War II and other like Korean War II, they compared it to, they realized that, oh my gosh, we're worse. Actually, we're not seeing improvement at all. We're actually, casualty rates are worse. And they were like, let's look at this. And they found it to where what happened was the IV fluids was flushing out the clotting factors of the platelets. And so otherwise, sometimes these patients would have clotted on their own, but we took that clotting factor away. So you have to be careful out there. We're gonna provide that 20 milliliters per kilogram of a fluid bolus to a patient, but we're going to stop that fluid bolus as soon as what? As soon as we get radial pulses to return. Because once radials have returned, we don't want to keep, bolusing this patient with fluids, because it can cause that hemodilution to where we're losing red blood cells more. We are causing the blood not to clot. Internal hemorrhage. Bleeding is inaccessible except through surgery. Increasing blood pressure, increasing rate of blood loss, in addition to other complications of fluid administration. So all of that should be on your mind. Achieving a balance between increasing blood pressure in severely hypotensive patients and avoiding worsening their condition. So we'd like to have a large bore IV. We'd like to infuse Ringer's lactate or normal saline, and we're going to give a 500 milliliter bolus, reassess, and then continue your 20 milliliter per kilogram bolus. Titrate to maintain a systolic blood pressure between 80 and 90 systolic. We want to keep these trauma patients warm. Right? We want to allow the critical trauma patient to become hypothermic can be fatal. So let's put a blanket over them. Let's do what we can to keep them warm. Hypothermia reduces the effectiveness of blood clotting, and coagulation reduces the ability to stop active bleeding, and just thus leads to more bleeding. Okay, y'all, that's going to be it for this chapter. I will get it posted. We will see you in class next week for your exam. Hope you study hard, and look forward to seeing you soon.